This week on the BackTable podcast.
So I reintroduced the balloon and I pushed the thing back up. And at this point, Ken turned to me and said, that's not the way daughter does this. I said, how does he do this? He said, well, he inflates the balloon above the lesion and then he yanks it down.
Oh.
Inflated.
Okay.
And I'm looking at him and I said, Ken, I've read a little bit about this. I never read anybody yanking this thing or even moving it while it was inflated. Are you sure that's what daughter said or did? Because I've never heard him say that. And I've heard him speak a number of times. Yeah, absolutely. So, we didn't get very far doing what we were doing.
Sure.
So let me see what the hell happens. So I inflated the balloon and I yanked.
Holy cow.
I yanked it down about 1.5 inches. And all of a sudden, there was a gush of blood out of the puncture site. There was a pulse. And I'm like, I'm a hero. And so I did an angio. It looked pretty good. And I said, okay, we're done. And I said, let me get the hell out of here as fast as I can.
Ladies and gentlemen, welcome to the BackTable podcast. If you're a new listener, welcome. For all of our regular listeners, welcome back and thank you for listening. You can find all previous episodes of the podcast on iTunes, Spotify, or our website, backtable.com. Now a quick word from our sponsor.
This discussion is supported by Philips OBL and ASC Solutions SymphonySuite, the industry leader in opening cardiovascular office-based labs and ambulatory surgery centers. With the convenience of a single trusted point of contact, they offer more of what you need to turn your passion into reality, including a full range of high-performing, highly specialized equipment and services, devices, financial options, site planning, guidance on construction partnerships, and more. When it comes to opening an OBL or ASC, SymphonySuite delivers convenience and support as the expert you need, the partner you trust. To learn more, visit philips.com/SymphonySuite.
And now back to the show. Got an exciting episode for you today. We have Dr. Sauce here with us today. We're going to be talking about his career and how that fits into the history of interventional radiology, newly retired. And let's see if I can give Dr. Sauce a reasonable introduction. So SIR president, 86 to 87, SIR Gold Medalist in 2009, number of publications, over 140, 60 plus book chapters and reviews, Charles Dotter Lecture, and on and on and on, and now recently retired Professor Emeritus from Cornell. Is that okay, Dr. Sauce?
And just got the SIR Foundation's Leadership in Innovation Award this year.
Man, the awards just won't stop coming, right?
As long as I keep breathing. Well
deserved. All right, Dr. Sauce, if we could just start out, can you kind of talk us through your training in radiology? What did the training look like then? You did a diagnostic residency, and then talk about your fellowship and how that kind of differs from the fellowship that we have today.
Starting in immediately after my internship at Montefiore, I began my training at New York. At the time, it was called New York Hospital, the New York Hospital, the Society. So I began my training back in '69 and it was a 3-year diagnostic radiology residency. I was lucky because it was just the year previous. They stopped having a 4-year radiology residency that included a year of therapeutic radiology, radiation therapy. And that would have probably killed me, literally. And so it was a 3-year training. I got very friendly with the guy running interventional. Well, at that time it was called Cardiovascular and Interventional Radiology. There was nothing interventional about it. It was cardiovascular.
Sure.
I had a 2-year fellowship. I think I was the first fellow at Cornell to receive this training. And it was a fellowship that was in part sponsored by the NIH. The training was 2 years, which turned out to be a real blessing. I was trained by Harry Baltax, who had been trained by Kurt Platz, and was a fresh young attending at Cornell, and David Levin, who came from Los Angeles and became an attending at Cornell just the same year when I started. So it was a pretty green crew, and fortunately they knew a little more than what I did. So basically, my training consisted primarily of some diagnostic arteriography, and specifically most of our time was spent doing coronary angiography. We did the coronaries, we read out the coronaries. In addition to that, we worked with the pediatric cardiologist to do congenital heart disease, cardiac caths, and we were responsible for the imaging and for the dictating of the films. So I became a cardiologist before I became an interventional radiologist. So the second year of the fellowship was really a gift because I was able to remain a trainee, but I was increasingly given independent responsibility for doing cases and reading them out and supervising the next year's fellows and the residents. So it was an absolutely idyllic existence. And I fell into all this because during my residency, during a rotation in this program, Harry Baltax and I began to talk about tennis, and he invited me to come out to the suburbs to his home, and we began to play tennis. And then when it came time for me to decide what to do with the rest of my life, and I was trying to figure out how the hell I would not die of boredom doing diagnostic radiology, he offered me a position. And of course, I jumped because it was the ideal compromise. I didn't have surgeon's hours, at least I thought I didn't.
Right.
I didn't have to talk too much to patients, at least I thought I didn't. It just turned out to be a wonderful 2 years. And of course, David Levin stepped into it, and he was a terrific person, and he played a large part in my life after I finished my fellowship. But we'll get to that.
Sure. So, Tom, like at the mood of the time, like so when you're going through fellowship and then also residency, were people calling it interventional radiology, or you were calling it cardiovascular and specials radiology? And was your fellowship representative of what trainees across the country were doing, or was it a little bit disjointed then?
Actually, the Society of the SCVIR, the old SCVIR, the Society for Cardiovascular and Interventional Radiology, was formed the year before or the year I became a fellow. There was really very little organized training going on. Everything was pretty ad hoc. I had enough trouble staying alive myself, so keeping my head above water, so I wasn't too interested in what anybody else was doing. Now, there was an informal New York Angio Club. The New York Angio Club met once a month, and I remember we had to bring cases. Just about anybody and everybody who did any angiography came to this. And we showed cardiac, coronary, as well as some peripheral vascular and diagnostic cases. This was just at the beginning when Stanley Baum introduced GI bleeding, and Charlie Dotter introduced using vasopressin infusion with Joe Hirsch for GI bleeding. So I was very, very lucky. I really got in on the ground floor. Drainages were just beginning. John Evans, incidentally, who was the chief of radiology at Cornell, had done the first transhepatic percutaneous cholangiogram. So he was a good mentor to have, even though he was way too busy running radiology to even know I was alive. But it was still a fun atmosphere.
So then from fellowship, if you could talk about, maybe the first arc of your career, like the first decade, you're a newly minted attending. If I read your CV correctly, you actually had a brief stint where you were away from New York. Did you take a job with Harvard and then came back to Cornell?
So what happened was when I finished my fellowship, I started my fellowship at the end of my 3-year residency, so that would have been 72, and had my fellowship at Cornell till 74, and I stayed on 1 year as an attending. At the end of that, or sometime during that year, David Levin was asked to come up to the Brigham, and he asked me whether I'd be interested in joining him there. the Peter and Brigham and Women's Hospital now.
Mm-hmm.
And since I had gone to medical school at Harvard and I had a wonderful time there, I indicated to him that, yes, I'd like to do that. They were doing basically the same stuff we were doing at Cornell, primarily coronary angiography. And so I stayed up there with Dave Levin. He was a real runner.
Okay.
And he was training for the marathon. And I had never even heard of such a thing as a running shoe. And Dave had a very expensive pair of running shoes, and I went up and bought a pair of running shoes instead of running in my tennis shoes. And so we were working, I was working my way up to several miles, and Dave and I were good running partners and became pretty good buddies. And sometime, and in the meantime, Harry Baltax had recruited Eric Martin, who just finished his training at Columbia under Bill Casarella, who later became a big shot in the ACR and became chairman of radiology at Emory. Anyhow, Eric took my position. Sometime in March or April, Dr. Evans decided to retire, and Joseph Whalen, who was the vice chair, was going to take over as chair of radiology at Cornell. So they together called me. And, in the meantime, Harry Baltax had decided that he was going to take the chairmanship of radiology in Omaha, Nebraska. So Dr. Whalen and Dr. Evans called me and wanted to know whether I'd be interested in coming back to Cornell and becoming division chief of Cardiovascular Interventional Radiology at the ripe old age of 35, I guess. Actually, I became so audacious that the following year, Joe Whalen offered me a clinical professor, that he would put me up for a clinical professorship. And I said, you know what? I might as well wait another year or so until I can become an unqualified full professor. So he giggled. And in 2 years, he put me up for an unqualified professorship, and I became the youngest full professor at Cornell, I think maybe ever. So in the meantime, Eric Martin, who was trained by Bill Casarella, was now at Cornell. When he found out that they had asked me to come and take over, he rightly was not very happy. And so the first phone call I had made was to Eric, whom I asked. I said, Eric, I know that this must be a tough pill for you to swallow, but would you be willing to stay on? And I promise you, I'm not going to treat you like an underling. He said in his very eloquent British English, well, Tom, that's very kind of you, but I believe there will be a job for me at Columbia, which meant fly a kite, Tom. But he said it much more nicely.
Yeah, when it comes with a British accent, it feels easier.
Well, the bottom line was I came back to Cornell in July 1, and not only was I division chief, but I also was chief cook and bottle washer. I, at that point, had no fellows, and so there I was. I was on call every night. There was a 45-minute drive without traffic, which was a good thing because most of the time I was doing it without traffic for GI bleeders, because this was the heyday of GI bleeders. And so there I was back at Cornell just about every night doing GI bleeders. I became pretty good at that. So I couldn't wait for the year to pass. Now, in the meantime, I think it was around this time or the year after that Andreas Grunzig began to run his courses in coronary angiography and angioplasty in Switzerland, in Zurich, at the Kantonsspital. And so I signed up, and he wrote back, we'd be happy to have you, but one of the conditions for enrolling is that you have to send me about at least 25 angioplasty cases, peripheral angioplasty cases, to demonstrate your competency.
Well, how many had you done at that point, Tom?
Well, this was a problem because I hadn't done 25 cases. Ken Snyderman, he was coming to interview with me. Somehow, miraculously, I had scheduled an iliac angioplasty for that day when I was interviewing him. And in those days, there were no balloons, or rather, the only balloons that were available were the so-called corset balloon catheters that were the early balloons. And I think it was actually, not sure whether it was Charlie Dotter who made them. And they basically were a Teflon tube, outer catheter, with 8 slits in it. And the slits were near the tip of the catheter. And if you put in an internal catheter, which was like a latex balloon, the corset, those slits, contained the expansion of the spherical, ever-compliant balloon that blew up like a balloon, but it was constrained by the corsets. And so it basically applied pressure over a very, very small length of the vessel, if you can imagine. It's almost like imagining the sphere, the Earth, and the longitude, latitude. There were 4 vertical slits.
Okay.
Parallel to the long axis of the thing that constrained the balloon. And so Ken was there. I don't know where the hell I had gotten one of these catheters. I think I may have brought it back. No, I wasn't in Switzerland by this time. So, but somehow or other I got a hold of one of these things. And I scheduled the case, and the surgeon who scheduled it did occasional vascular surgery. And he was a lovely guy, a lovely young guy who trained at Cornell. Coincidentally, he was one of the first, if not the first, black surgeon at Cornell. So he was a big deal, and a very cute, very smart, very nice guy. So I don't know where he got the balls, but he allowed his patient to become my guinea pig. So with great fanfare, they brought the patient down, and everybody's standing around watching. Ken is there. I said, Ken, have you ever done one of these? He said, no, but I saw one on TV. No, he actually had seen Dotter do one the day before.
Okay.
In Portland, in Oregon.
Sure.
So I figured that was one more than I've seen. And it sort of was the closest thing to the Three Stooges. But, I mean, I had done angioplasties using the Fernandel catheters. Do you guys even know what a Fernandel catheter was? Dotter's original catheter was the coaxial dilator set. And what he had was he would introduce a Teflon dilator over a guide wire through the stenosis and coaxially over the first catheter, which didn't have a hub on it. So you could pass the second catheter over it.
Okay.
The second catheter was no longer really tapered to a tip. It was tapered to the outer diameter of the first catheter. And you push that over, and that went through the lesion. And there were 2 or 3 thick-walled dilators that were each tapered to the other, to the preceding one.
Yeah, sure.
And you just kept passing these over until you got some kind of an angioplasty. So there were a couple of things wrong with this. Number one, the tip was fairly blunt. And if there was any loose clot and or atheroma, you simply showered it distally. The second problem was that as big as a hole as you wanted to create at the angioplasty site, it was an equally as big hole you created at the puncture site. And there were no closure devices. The only closure devices was manual compression for a good 30 minutes to an hour. In any case, I had done that, and with variable results. But this was my first quote-unquote balloon angioplasty.
Sure.
So I put this thing in, and I introduce it. You know, I do a careful angio, and I carefully introduce it to the stenotic segment. And I said, okay, Ken, here goes nothing. And I inflated the balloon, and of course it squirted right out of the lesion.
Immediately, right? It's a perfect sphere.
So I said, well, I think what I have to do is I can't probably push it enough high upwards. So what I'll do is I'll inflate it partially just above the stenosis, and then I'll pull it back a little bit, and I'll try to inflate it all the way when I have it in the narrowing. And it was a relatively short segment narrowing. So I figured this would work. So then it squirted below. And I played with it for a little while until I thought I finally sort of caught it. And I did a post-angio shot. I pulled out the latex balloon catheter and I injected some contrast. Nothing much had happened. Nope, nothing bad happened either.
Nothing bad happened, but nothing great happened.
It was worth celebrating, you know. And so at that point I said, well, let's try this again. So I reintroduced the balloon and I pushed the thing back up. And at this point, Ken turned to me and said, that's not the way daughter does this. I said, how does he do this? He said, well, he inflates the balloon above the lesion and then he yanks it down.
Oh.
Inflated.
Okay.
And I'm looking at him and I said, Ken, I've read a little bit about this. I never read anybody yanking this thing or even moving it while it was inflated. Are you sure that's what daughter said or did? Because I've never heard him say that. And I've heard him speak a number of times. Yeah, absolutely. So, we didn't get very far doing what we were doing, which was according to previous deductions.
Sure.
So let me see what the hell happens. So I inflated the balloon, I looked at the roof, and I yanked.
Holy cow.
I yanked it down about 1.5 inches. And all of a sudden, there was a gush of blood out of the puncture site. There was a pulse. And I'm like, I'm a hero. And so I did an angio. It looked pretty good. And I said, okay, we're done. And I said, let me get the hell out of here as fast as I can.
So that worked. So on your post-angio, you had some lumen...
Not so fast. It worked. I mean,
okay.
It looked okay. I didn't really have a whole lot of time to look at it.
Sure.
So I figured I'd better get the hell out of there before something else happens. So I pulled the catheter out on the table, and I held pressure. And about 3 or 4 minutes in, I noticed that the pulse was disappearing.
Mm.
And within another 5 minutes, I no longer had to worry about holding pressure because there was no pulse. And at this point, I called the surgeon. He came down and he said, what's going on? And I said, well, I did an angioplasty and we had a great pulse. Here's the angiogram. And I immediately pulled out the catheter and began to hold pressure. And then the pulse disappeared. So he looked at me and he said, so the whole thing thrombosed, right? I said, well, probably. I said, okay, we'll take him to the OR, which he did.
Sure.
And the entire iliac artery was clotted. So that was my first angioplasty, or first balloon angioplasty. In any case, Ken then took the job.
So after all that, Ken was like, oh, this is a great place to work. I want the job.
Well, I didn't think that I would be giving him a great recommendation, nor did he. So he took the job with me, and the two of us continued on, and we then had 2 fellows and 2 attendings, and that was the year when we actually really began to do angioplasties, but continuing to use this crazy balloon. Mm-hmm. But I learned not to yank on it. And I built up a caseload large enough to satisfy Grunsik, who then invited me to his meeting, which was where Bill Casanova from Columbia and I traveled together for the 2nd annual course at the Kantonsspital. We watched coronary angioplasty. In those days, the coronary angioplasty balloon that Grunsik was using had no guide wire lumen.
Oh, wow.
So he put it in through a guiding can. It had a little wire that you could pre-shape on the tip. And so he just basically navigated it from a guiding catheter in the ostium using the shaped wire through the stenosis and did the angioplasty. And that seemed to work pretty well. So we became, I don't know whether we got it. I think I actually got a diploma of sort, which over the years I lost. And I remember we came back to New York with a bunch of Schneider balloon catheters.
Did you buy them over there and you just carried them on the plane back with you?
Yeah.
Okay.
And okay. So the truth is I have no idea. I may have ordered them. No, I mean, that was in 76.
Okay.
I remember I got them,
All right. Got you.
acquired them. And then, so when I said them, it's a bit of a misnomer. Mr. Schneider in his garage could make only a limited number of things. I still remember it was a bright blue thing, very pretty. Grunzig at that point, or a couple of years later, began to work with USCI Bard, who then began to make catheters in the U.S. But at this point, Mr. Schneider and maybe an assistant were hand-making these things.
Wow.
And I remember I came back to New York, and soon after, I had the balloon. Now, I became a celebrity in New York because I was the only one. All I know is that at the next angio club, I showed a case using this catheter. After that, of course, this was in the days when catheters were still re-sterilized.
Right.
All diagnostic catheters, these things were re-sterilized because they were expensive. It was years later that they finally figured out that all the pyrogenic or often pyrogenic reactions patients had after a diagnostic arteriogram were most likely due to some foreign substances that were left from blood products and or the sterilization products. And the FDA put an end to it for a while, a long while. But in any case, the balloon catheter became a treasure. And I could have made a lot of money because what happened was people began to call and they knew I was re-sterilizing it. And they said, listen, I have an iliac coming up. Can I have the catheter? And it was an 8 millimeter by 3 centimeter long catheter.
So one size. So you have this one size balloon.
Yeah, one size had to fit all. Or all had to fit one size.
All right. Yep.
So I still remember they would call up and I said, listen, send a cab. We will send somebody down with the catheter and take good care of it because it's the only one.
Wow.
And whoever breaks it is in deep shit. It really lasted for several months.
Okay.
And then I can't remember what happened. And so that was my introduction to being a catheter landlord and renting it out.
So this is your early foray into balloon angioplasty. So how many cases were you doing, and then what did the next phase of angioplasty look like? I mean, I'm assuming like after this.
So I need to go back to coronary angiography because that became an interesting story too. So in the meantime, the arrangement with C.W. Lillihei, who had been at University of Minnesota and was an interesting character, he was sort of the Donald Trump of cardiothoracic surgery. He was known as, even though half his neck had been dissected away for I don't know what, he patronized whoever it was that he could patronize. He was a fabulous surgeon. He was not known for showing up early for his cases, so the residents and fellows opened chests and closed chests.
Wow.
But when it counted, he was there. He did not like the adult cardiologists. And so the arrangement had been up until he arrived on the scene that I would do the coronary angiography, and if the patient needed a cardiac cath, they either came back another day or there was the cardiac cath lab and my lab were next door to each other. So the patient got shipped over by one of us to the other, or we repunctured the following day, whatever. So they did the cardiac cath and I did the coronary angiography. So one day, CW comes over reviewing the coronary angios. And by the way, he was the only guy who actually ever came down to look, or he was one of the internists had no idea which end of the coronary was up. And so they hardly ever came down to look, but he always did. And I actually liked him. He was a great guy. So one day he turns to me, he said, Tom, says, it doesn't make any sense to ship these patients all over hell to those idiot cardiologists. Can't you do a cardiac cath? Can't you do a cardiac output in the valve area? And I looked at him and I said, of course I could. having no frickin' idea how to do
Either of those things.
I knew how to get a gradient.
Sure.
And I had a textbook that I carried back with me from the Brigham. There was a cardiologist called Grossman. He was a pretty obnoxious character, but he wrote a pretty good textbook of cardiac catheterization. So I opened up my Grossman, and I always kept saying he was such a gross man. I hope he's not alive and listening.
I highly doubt he's listening, but maybe.
Well, at some point. But you know what? It's okay. I mean, he and I actually got along. He was just a little difficult. So I opened up my Grossman, and I made a couple of phone calls, and I figured out, as it was, we were already doing cardiac outputs. Actually, we did the ejection fractions, and you're not going to believe how we did ejection fractions. You projected the cine. You had a cine projector or a cine viewer, and so you put on the left ventriculogram, and you put it onto the greatest ventricular volume, the height of diastole and diastole, and you put on some tracing paper, and with a pencil, you traced the ventricular contour. Remember, this is 1977.
Sure. Fair.
Before AI and before very much intelligence on my part, I might add. So anyway, so I put on the tracing paper, I traced end diastole, and then on the same piece of paper, I traced end systole. And then I read in the trusty book that I needed a protractor. So I went out and I looked around that I couldn't find a protractor anywhere in radiology. I wasn't going to ask the cardiologist because I would sooner die. And I went and bought a protractor at the Cornell medical bookstore. So the task was very cumbersome, but easy. I mean, even an idiot like me could do it. And I traced the diastolic contour, and then I traced the systolic volume and curve contour. And from that, it was very easy to calculate the ejection fraction. From then on, I learned how to inject green dye and do the cardiac output. I could do pullback pressures across the aortic valve or do a wedge and get the mitral gradient or pressure through the wedge. And I became a proper little cardiologist. In the meantime, the cardiologists were beginning to sense that things were not going well. Lily I and his cardiac cath patients were becoming somewhat hard to find.
Okay.
And the internists continued to send patients. And so they asked me if I would teach them how to do coronary angiography. And like a good little puppy, you know, in those days, I was not the favorite pet in radiology because Joe Whalen was by now the chairman of radiology, and he was working very busily on not just the single plane CT, but trying to do primitive reconstructions and using CT to sort of do volumetric reconstructions, or at least in your mind reconstructions.
Okay.
I remember CT at this point looked more like a Rorschach test than a diagnostic exam. But he and Eli Kazam, my co-resident and then co-attending, he became the chief of body imaging. And at that point, our cardiac echo consisted of bipolar ultrasound. Bipolar ultrasound sort of looked like the sonar that ships used to detect icebergs. I'm not kidding you.
Okay.
Because it was the summation of many of those. So this is where we were practicing medicine.
Okay.
So up to this point, angiography was king, because the only other special procedure was a nephrotomogram.
I don't know what a nephrotomogram. I would have guessed it. I would have guessed it was with the kidney.
Okay, so the IVP was, as you know, they injected dye and they
Got it.
a flat plate before injection, immediately after injection when you got the nephrogram, because it was really an IV arteriogram, or at least the arterial and capillary phase. So they did an immediate film, and then they kept taking films, I think, at 5, 10, and 15 minutes, and then at the end, 30 minutes when the bladder was filled and the calyces were filled, And they used to do tomography, usually for the chest, when they were looking for nodules. And the tomogram was simply the X-ray tube would swing over the patient and record an image during its swing. So it was almost like a single slice, but a very primitive slice.
Right.
So that was a tomogram. And then Dr. Evans began to do nephrotomography, which crudely could detect intraluminal filling defects, stones, and as well parenchymal bumps.
Okay.
Surface bumps,
Sure.
or even parenchymal bumps or cysts, which had a different density. And that's when they began to learn that cysts had very sharp interfaces with the parenchyma, where tumors bulged out and blah, 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 blah. So that was the science. But, we were kings in angiography. And then Joe Whalen and Eli Kazam came along with bipolar ultrasound a year or two into my kingdom.
Sure.
And they began to do CT. And Whalen made this his career to optimize CT and to improve it, because at this point there was even some question whether abdominal CT. I mean, I still remember when Hounsfield from England came to Cornell, and he gave a lecture. It was one of the first lectures in the U.S. And he talked to us about this newfangled thing called computerized tomography. And he showed some images that were, like I said, a Rorschach test.
Right.
But it improved very rapidly because people began to realize. However, there was some serious question in these days whether it would ever be applicable to the abdomen because of breathing.
Sure.
Or not.
Right.
Respiratory and bowel motion. But they made pretty rapid advances to the point where 3 or 4 years later, Joe Whalen was given the Caldwell Lecture of the American Röntgen Ray Society. I remember the meeting was up in, I think it was Montreal, not Toronto. He gave the Caldwell Lecture on the rising role of computerized tomography in diagnostic imaging. And of course, he got a great ovation. And during his talk, he mentioned that computerized tomography was replacing angiography at Cornell and was going to replace it all across the world. And of course, I'm sitting there and all my buddies are looking at me. Really? We're being replaced? And so I, at this point, I had to redeem myself. And I joined the adoring crowd milling around Whalen at the end of his lecture. And I finally sort of nuzzled up to him and I said, Joe, he was an egomaniac.
Okay.
So are we all. But I said, Joe, wonderful lecture, certainly very exciting. And I understand that it will have its place, but at least you could have mentioned that we are still doing a lot of diagnostic arteriography and that we are beginning to do interventional procedures, and they are taking up the slack, and they are the new face of angiography/interventional radiology. That would have saved my face.
Sure.
And he looked at me, and if looks could have killed,
this one was deadly.
On a good day. And he looked at me for the last time in almost a year. From then on, he merely and often looked through me at departmental conferences when he only called on me if it was absolutely unavoidable. And it was a year before he actually spoke to me ever again. So in the meantime, back to cardiology.
Yeah.
So all this is going on in the background.
Okay.
And I didn't exactly have the best defenders available. So at this point, when cardiologists said, we'd like you to teach us how to do coronary angiography, we already know how to handle catheters around the heart. So I said, well, okay. So I thought, you could teach a monkey how to do coronary angiography.
Teach anyone how to do this stuff, sure.
And you can teach anything to anyone. Well, once you get your MD, it's a license to kill. And you're not supposed to, but...
Yeah. Good tip for the younger guys.
So here I was, teaching the cardiologists how to do coronary angiography. So pretty soon it became a sort of tit for tat. If they had a cardiac cath to do, they would do a coronary angiogram on that patient. If I had a cardiac cath for Lily High, I would do a coronary angiogram on that patient. And we were going along. Everything was hunky-dory until I went to Switzerland. So at this point, I called myself the missing link, because years previously, when I didn't do very well in college, I went to Queen's College before Harvard Med School.
Mm-hmm.
My dad, who was a physician, was from the Prussian-Hungarian families, and he was very Prussian in his enforcement of the rules. So when he began to realize that I was getting not only A's and B's, and the B's were bad enough for him, but C's and D's in college, and that this had been going on for a while, he basically invited me to leave our apartment, which was upstairs from his office in Forest Hills, and I got exiled to the office, and my stepmother snuck me food occasionally, and of course I had to be out of the office before office hours and couldn't return till 9 o'clock at night. Not great arrangements. But in the meantime, he also told me that I needed to get out of day school and I needed to get a job, because obviously I wasn't all that interested in studying.
Sure.
I never liked studying. In Hungary, they made you memorize, rote, real Prussian memorization without any meaning, or they didn't give a shit if you knew or if you understood what you were saying, as long as you could recite it literally verbatim.
Gotcha.
I still will never ever forget the high point of my life. I was really good in geometry.
Okay.
And we were studying the definition of a point, a line, and a circle. You can sort of see how they belonged in one chapter.
Okay.
And so you had to obviously memorize it. And he would call on the first guy. I was the first guy the teacher called on. And the moment you made a mistake, you left out a the or an or a whatever.
Mm-hmm.
As long as you were not reciting what was in there, it didn't matter if you understood it.
Sure.
So,
had to be able...
needless to say, I was done in 2 minutes. And then in mere 15 minutes, he examined the entire class. And so that was typical of school in Hungary.
Gotcha.
And if I ever had any great enthusiasm for school, that killed it. So here I was in America, having to be a student at Queen's College. I was probably a little bit dyslexic too, but nobody ever heard of that.
Right.
In any case, so here I was reciting all this stuff, or at least trying to memorize it, and it wasn't going well. And so he said, "You got to get a job." So I got a job. I knew some friend of a friend who worked at an insurance company, New York Life, downtown.
Wow. Okay.
And she gave me a job as sort of a gopher. And basically my job was, since I was not completely stupid, to fill in. So if they needed somebody in accounting, they sent me over there. If they needed me in whatever part of New York Life, they called her, and I always had to check in with her in the morning, and she would assign me to wherever I was. So soon enough, I began to refer to myself as the missing link at New York Life. And so I became the missing link now at Queen's College, where I was missing most of the time. Anyhow, so after I did pretty well during that semester, because I realized that even studying was better than being the missing link.
Sure.
So I got back in day school. There's a reason why I began to tell this story.
You're talking about being the missing link between cardiology and interventional radiology.
That's right. So I was the missing link, because I told them coronary angiography. I told them how to do the cardiac caths. And at this point, they realized that I was becoming a problem. At the same time, I went to Switzerland, and not only did I come back with the iliac balloon, but I also came back with a set of coronary angioplasty balloon catheters and guiding catheters. as the first year, I remember I told you I was the only person in our
Yeah. Right.
And so it was very important to spread the word. Well, how do you spread the word when nobody knows you exist? And so I made it my business to make sure there were never any cases scheduled when there was an important conference. And so I ended up going to GI conference, GU conference. At that point, Irving Wright, who discovered Coumadin, was in charge of the medical peripheral vascular conference. And of course, I had to endear myself to Irving Wright. And I did, I must say, and he became a great supporter.
Excellent.
And I went to the urology conference, which became a big deal. And I found out that there was a hypertension conference, which was run by Dr. John Lara. Dr. John Lara had just come over from Colombia. He practically invented renin, and he was the world's expert. No, seriously, in renal vascular hypertension and hypertension. He was not a cardiologist, but he eventually became chief of cardiology, which is a whole other story too. And it was a beauty. So here is John Lara, and I began to do angioplasties. I went to Lara and I said, can I come to the hypertension conferences? And of course, when a renal artery stenosis came up, they began to discuss, which surgeon to send it to.
Okay, so they were managing that surgically at the time. Gotcha.
Yeah. I went to Dr. Lara and I said, this newfangled stuff that I'm doing, you may have heard about me doing angioplasties. Would you be willing to let me try one on one of your patients? And he said yes. So I actually did one. Of course, they had the OR on standby. That was routine for the first year or so.
Okay.
Not only at Cornell, but everywhere else. I was one of the first, if not the first. In New York, I was probably the first, and one of the first anywhere in the world to do renal.
Okay.
And I still remember I had absolutely no freaking idea what was going to happen when I blow up the balloon, if I ever got that far.
Sure. But at this point, you had done renal angiography. So renal angiography was...
Renal angiography is easy.
Gotcha.
Now you had to get through the stenosis.
Sure, right.
We did not have 018 guide wire. You had a Benson or a Rosen J. That was about as good at 035, was about as good as you had. And you didn't know about spasmolytics because you didn't know about renal artery spasm until you induced it, which was not a good time to find out.
Sure.
So we wrote a lot of great papers on all the new things we met. But anyway, so I managed to get through this thing. I didn't do any harm. I actually got the artery opened. Lara was suitably impressed. And so that opened up a whole new channel. But in the meantime, I was still doing primarily coronary angiography and some diagnostic angiography. And so I was going to the pediatric angiocardiography conference where I presented all the imaging data. And then I would go to the adult cardiology conference where I would present the coronaries that I had done. And so I was the missing link going to all these conferences, trying to beat the drums and to have everybody know I existed and everybody think that even if I wasn't, that I was the smartest, cutest, brightest, young. It was sort of amazing to walk into any room and be the youngest and the smartest. And even though I wasn't all that cocky or confident, but act like I knew what the hell I was doing.
Sure.
And so I began to get referrals from all over and things began to grow. So in the meantime, I come back with the Grunsig coronary catheters. And I go to one of the cardiology conferences. And of course, cardiologists, even though they like to pretend that they know everything and that they are really cool and up to date,
sure, in
those days, not so much.
Okay.
So I'm sitting there and we are discussing a 50% LAD stenosis that was symptomatic. And in those days, that was the same discussion as we had about somebody with claudication. the dictum for many years was that you didn't treat anybody with claudication, because if anything went wrong, you could convert them into an amputee. And that was not a great thing to do. And so we were extraordinarily conservative in how we approached every single stenosis, no matter where in the body. But in the coronary especially so, because the teaching was that if you had a mild to moderate focal single vessel lesion, unless it was a left main, you left it alone. And it was a left main, you left it alone because that was a surgical case for many, 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 many years to come. Because again, if something went wrong, it was curtains. Anyhow, it came to this case, and the learned ones discussed it and said, well, I think, we're just going to have to watch him if he develops something more or something worse, or the angina gets worse. So I spoke up and I said, well, listen, the angina is bad enough. And he's complaining. He doesn't quite have rest pain, but he's pretty close. And so I said, I think I've seen the future, and I will be applying for an IRB in coronary angioplasty. What's that? I said, well, it's what I've been doing for a couple of years now. You put in a balloon into a narrowing, and you huff and you puff, and you blow the stenosis out. And they looked at me with their jaws falling over, and I could see them perking up and listening. Because stupid they were not. And I could see the wheels turning. So the next day I had a delegation in my office, and I told them that I was putting in the IRB, and I would put the head of the cath lab. It was a protected, I will not mention his name.
Okay.
If it comes out, it comes out. He was a pretty tough, obnoxious guy. But I told him that I was going to put him on as a co-investigator on the coronary angioplasty protocol. It was kind of fun, a whirlwind anti-romance. In the next 2 days, I found out that cardiology, of course, there were no computers and there was no email, but they wouldn't have used it anyway. They passed the word around to every single medicine person. We're talking about resident, fellow, attending, cardiologist, non-cardiologist, probably the nurses. I wouldn't be surprised if the cleaning lady also knew that there were no further referrals to SOS for anything.
Wow. Shots fired.
So here I was, the PI on coronary angioplasty. The only problem was I had no access to any patients.
That's right.
And at this point, I knew that John Lara was now the chief of cardiology, and he was my buddy.
Okay.
So I went to see my buddy, and of course I realized that the heart is thicker than blood, and I could go fly a kite, basically.
Ouch.
He said that he understood, and he loves me dearly. However, as chief of cardiology, wearing a different
the chief hat,
from being the father of renal vascular hypertension. And incidentally, I had written a letter proposing him or supporting him for the Nobel Prize in Medicine, which he came within a whisker of getting.
Wow.
He should have gotten. But in any case. So he said, look, I cannot go to war with the chief of cardiology and the head of the cath lab over this, and it's their decision. So, I will continue to send you renal angioplasties. Listen, when you're a beggar.
Right. But that certainly launched you into a different part of your career that maybe had more legs than anything else, right? I mean,
so this is the irony of how things turn out. Now, one of the funny anecdotes there was a very famous internist at Cornell. The guy's name was Dr. Foley. Dr. Foley was about 5'4", very patrician, silver-haired, comb back, straight. He was always in a double-breasted white coat with his name monogrammed.
Very nice.
And he had this 100-year-old medical bag that he always slapped under his arm and walked around with it. So anyway, he was one of my referrers for coronary angiography.
Mm-hmm.
And he'd been an all-time internist. He was probably most famous for having been, don't ask how, but somehow affiliated with the U.S. military during World War II, and he was stationed in China.
Okay.
And allegedly, he was dabbling in all kinds of stuff. And among other things, he managed to lose the Peking man. And apparently there was this very famous skeleton that was like the key to everything.
Like the true missing link.
The true missing link. Dr. Foley managed to lose the frickin' thing. Anyhow, so now he's back.
Okay.
And he is a very high society, not just doctor to the high society, but a part of it.
Okay.
So I had a patient of his scheduled for a coronary angiogram, I don't know, to be down on the floor at 9 o'clock, whatever, in the morning.
Sure.
And, we are in the lab treading water, 9:30, no patient. So finally we called up to the floor and we said, "Where is this patient?" And they said, "Oh, we are having some troubles with him, some difficulties."
Okay.
And I said, let me just go up and see what the hell is going on.
Sure.
So this was in what they called the tower.
Okay.
I don't know if you know the Cornell Medical.
Not so well.
So the Society of the New York Hospital. So 1930s building, very Art Deco with arched Romanesque windows, white brick. I mean, it's a spectacular building.
Sure.
You can look it up later. And the tower was the central building, and they had patient rooms all the way up. And they were from the 5th or 6th floor up. They were all private rooms.
Okay.
And remember, this is going back to the 50s and 60s. There were no private rooms except for those who had a private room.
Gotcha.
Everybody else was in a 4 or 6 bedded ward.
Right.
So now, fortunately for me, the elevator service was terrible. And one of the reasons at 81 I'm so fit, I'm still skiing. I'm still skiing double black diamond bumps off of the peak in Lech, Austria, and that Snowbird, and you name it. And I'm biking 30, 40 miles at 16 miles an hour. Anyway, so the foundation for this healthy
fitness
is that when they built the hospital, they didn't really give a shit about what people like the house staff or the nurses were doing.
Sure.
All they wanted to make sure was that the tower was well supplied. So there were 4 elevators that supplied the private rooms in the tower. In the rest of the hospital, there were maybe 3 or 4 elevators for the ordinary pedestrians and plebeians.
Right.
And the radiology department in those days was on the 6th floor when I was a resident. So, hospital floors, particularly in the old days, are double height.
Yep.
Or ordinary.
Mm-hmm.
So back in 1969, I began to run up the stairs instead of waiting for the elevator because I was never very good at waiting.
Okay.
So I would go running up, and everybody, when I came out or went in to the staircase, would stare at me. And pretty soon it became clear that they thought I was crazy. And not for that reason alone, but they, people were calling me the crazy Hungarian anyway, because I was always into everything and running and doing things. Oh, there goes that crazy Hungarian again.
Sure.
So running up the stairs, and I was running up 2 steps at a time. Remember, I was in my 20s. Why not?
Feeling good.
Feeling good, man. And so, here I'm running up. And I was very early on, a orthopod told me, do not even walk downstairs because all you're doing is pounding every one of your joints.
Sure.
So I tried to take the elevator down. Good luck with that. And I couldn't jump out the window. That. In any case, so I go running up to the 20th floor. IR was on the 4th floor.
Okay.
So I'm charging up, and I arrive a little out of breath. And as soon as I get off the elevator, I find myself in the middle of a carnival. And I look around and say, what in the hell is going on? So I realized pretty quick, it wasn't a carnival, it was a resuscitation.
Yeah.
And they were resuscitating, unbeknownst to me, my patient.
Sure.
And Dr. Foley was standing off to the side with his little medical bag. And he was getting a little impatient because it was 11:30. And I didn't know this at the time. So he's standing there, and the patient's family is standing around. And he, the resuscitation is going on. And apparently the story turned out to be that he's a young guy in his early mid-40s who really did have angina, but young men, and especially healthy young men, are more prone to vasovagal attacks or vagal attacks.
Yeah.
And so this guy, when they tried to put the IV in him, went vagal, and then he slowed down to the point where they called the code.
Okay.
And of course, the family was standing around because this was still the 70s, and, not everybody was having a coronary injury. And so they're all standing around watching the show. And so I arrive on the scene thinking, oh my God, what am I getting involved in? And Foley looks impatient, looks around, looks at everybody, looks at me, says, I'm leaving. I leave, and he had this phony British accent, I leave Dr. Sauce in charge. And with that, he re-slapped his little white bag and went off to lunch at the club. I'm not kidding you. That was the Society of the New York Hospital.
Okay.
So he was out of there. So I ran the code or finished it up, such as it was. Because fortunately, the nurses knew what the hell they were doing.
Sure.
And the interns and residents knew what they were doing. I was looking like I knew what I was doing. So there's a reason I'm telling you this. So after the code is over and I got the patient resuscitated, and so the wife of the patient comes up to me afterwards when things quieted down, and, we decided that was not a good day to have his coronary angio. And so the wife comes to me, pulls me to the side and says, Dr. Sauce. I said, yes, thank you very much. Would you be willing to take my husband on as your patient? Now, at this point, we were not admitting or seeing patients.
Okay.
And I said, look, I'm so sorry, but, I'm a hospital employee. I only do the coronary angiograms, and I'm not actively, I don't have patients, and I don't see patients. And she looked at me, and she said, well, I'm so sorry because you really seem like you're very caring and very knowledgeable,
Sure.
And she said, well, could you introduce me to the chief of cardiology? And I will try to get him to see my husband. I looked at her and I said, I don't know how to tell you this, but the chief of cardiology is not really a cardiologist. And she looks at me like, what in the hell am I doing in this place? And what's my husband doing in this place? And my husband's doctor puts his bag under his arm and he goes off. She didn't know he was going to his club.
Right.
But, and then the doctor taking care of her husband doesn't see patients. And the chief of cardiology is not a cardiologist. Anyway, so circle back.
Okay.
So anyway, so I was basically told that I couldn't do coronary angiography anymore. I was done.
Okay.
And at this point, I began to realize that I was in deep shit and I really needed to take things more into my own hands.
Okay.
And I began to sort of lean more heavily on Dr. Irving Wright, on some of the other internists who did peripheral vascular disease. And fortunately, there was a large group of them. And up to that point, they had rocking beds. And these beds, to restore or to get some circulation into these people who were severe claudicants and or limb loss, threatened limb loss, the beds would literally oscillate like this.
Wow.
Just tilt back and forth, raising the head, raising the leg, to try to get some blood in there. And so that was it. That's what they had. And
Low bar, and Coumadin.
And Coumadin. So anyway, so I began to talk to them. In the meantime, head of vascular surgery was a good Southern boy named Malcolm Perry. This is another one of those. I don't know.
Okay. Sure.
I don't really have a major issue because I'm telling the truth.
Right.
So Malcolm Perry came from Lubbock, Texas, where he was at the University of Texas. And the chief of surgery was, I'll think of his name when I don't need it. He was Tom somebody.
Okay.
Now, the chief of surgery was also the dean of the medical school. So he had a lot of hats he was carrying and a lot of power. So the chief of vascular surgery, who sent patients to me for an arteriogram so he could operate, was very, very reluctant to have me do any angioplasties on his patients.
Okay.
I was doing some on, there were a couple of vascular surgeons who were a little more willing to send me patients. I mean, this is a couple of years into this. And so it's still very early on, and I'm still gathering my cases for Brunswick.
Okay.
Or maybe I had just been there. I can't remember. But anyway, this guy goes to national vascular surgery meetings and tells everyone that in his good Southern drawl, well, at Cornell, we've had nothing but troubles with angioplasty, nothing but complications. It's a disaster. This was his lecture.
Wow.
And so one day this got back to me. Or rather, I used to also lecture at vascular surgery meetings.
Okay.
So I either overheard it or heard it. And I went back to my chief, Dr. Whalen, who just began to speak to me again. And I said, listen, Joe, this isn't good for you either. And we really need to get this straightened out. And I knew that the chief of surgery was his buddy.
Yeah.
And so I said, listen, you got to talk to him, and we need to really get this straightened out. I had done maybe 50 cases by this time.
Okay. Gotcha.
And I said, look, I think the only way this will work is if you get the chief of surgery and the chief of vascular surgery, and you and I sit down, and I'll bring the 50 teaching files.
Yeah.
And we'll go through every case I have done, and then I will ask, I'll show the complications,
of course,
of which there were a few, and nothing insane, but, when you do procedures, you get complications. In any case, so he arranged a meeting, and the guy sat through it, and he was a little bit dumbfounded because he realized that he was a son of a bitch.
But you could see that come across his face. Yeah, the realization.
And actually, even before this, I remember once he pulled me aside when I was trying to convince him to let me do an angioplasty on one of his patients. And he looked at me and says, Tom, do you actually know what the inside of an artery looks like? And I looked at him and I said, Malcolm, even at Harvard, we studied pathology in vascular pathology. And he looked at me like looks could kill.
Yeah.
So anyway, that was the background of all this.
Sure. Gotcha.
Now, pretty soon I began to make some serious inroads. And so it was getting to the point where they began to realize that I was beginning to eat their lunch. Not only was I doing the impossible cases, not only was I getting internists to send patients, so all of a sudden, the vascular surgeons announced, and by the way, this was not just happening at Cornell.
Sure.
This was a national and international trend when everybody began to realize that we were eating their lunch. And if they didn't watch out, or rather if they didn't learn how to do angioplasty, they would pretty much run out of work. And so all of a sudden, they convinced the chief of surgery, who was also the dean of the medical school, that because up to then, we sort of had the franchise. Actually, it was, I think, a written contract that radiology did all the angioplasty.
Oh, wow.
Now, that was we'll get back to cardiology in a second.
Sure.
So they basically abrogated the whole deal, and they said whoever is qualified can do it. Well, of course, they didn't know how to do it.
Right.
So that's when the surgeons all began to take 2-week courses on how to do angioplasty. You can imagine how well that went.
Sure.
For the first year or two, they were doing their cases in our lab, and so I had first-hand view of
the carnage, the wreckage.
It was truly, it was sort of like the Biden foreign policy. You can edit about too.
Okay.
But it was Afghanistan quadrupled and
Okay.
all the rest of it. Because it was obvious they didn't know what the hell they were doing.
Of course.
They had no business doing it. And in fact, I gave a lecture. So I was a regular at Barry Katzen's course I set in Miami at this time. But I had also been to his course when he was in Virginia, when he was in Alexandria. And Barry was 1 or 2 years behind me in residency at Cornell. And he and I had a difficult time because Barry decided not to do a formal fellowship.
Okay.
And Harry Baltax, the guy who trained me, did not like the fact that Barry was trying to do it short of doing a fellowship.
Right.
And Plinio Rossi, who was sort of the star of Italian angiography, at that point had moved and worked at St. Vincent's in the Village. And Barry Katzen did sort of a rotation with Plinio. And soon Plinio moved back to Italy. And Barry went to Italy and spent a year working with Plinio. So he ended up doing a fellowship.
Okay.
Basically.
Right.
And so here he was at Alexandria and then in Miami and running the course. And by this time, I realized that things were getting pretty bad with the vascular surgeons. And I befriended the chief of vascular surgery at the University of Colorado, whose name I'm forgetting at the moment because I didn't prepare well enough.
That's okay.
Rutherford, Bob Rutherford.
Okay, gotcha.
And as soon as I try not to think about it, so Rutherford and I started talking at a vascular meeting. And in fact, he invited me to lecture. He had a meeting that he held in Vail. And he also spoke at Frank V's vascular meeting in New York. So he and I began to talk. And I said, you know what, this is totally insane that we are doing this. And I used the words, I said, Alan, we are fighting over vascular disease. And after all, it's all about the patient. And you guys are busily learning how to do badly what we already know how to do well. There ought to be a way that we can sort of work together. You have your expertise in surgery. We have ours in angioplasty. Maybe over the years we can evolve and change. But why don't we form a vascular center where we could even have some guys who are wound healing specialists, whatever. Right. So he and I began to work on this, and the SIR and the SVS developed a program, and he and I were the co-chairs. Right. Now, later, if you would ask Barry Katzen, he invented the concept of the vascular center talks and conferences and conversations. With absolutely due respect to Barry, who really has invented pretty much everything else that has to do with politics in vascular disease, I really was the first one to start this.
Gotcha.
Barry caught on very quickly and joined. And so there were two things that Barry and I had a little bit of friction about. One was that my ex-boss, Harry Boltex, was down on him. And so for a couple of years, I didn't get invited to Miami because the guy who trained me was insulting Barry. And this was a little bit of a subterranean, never discussed boo-boo. And so one year, I got the Tegmeyer lecture.
Okay.
And my topic was vascular centers,
Cool.
the future.
Mm-hmm.
And I went into all this and including, why are people busily doing how to do poorly what someone else already knows how to do well? If you are the patient, how does that make any sense?
Of course.
So in the meantime, we're back to back to Cornell, back to the heart, back to the peripheral vascular. And now everybody's doing it. And it was a free-for-all.
Mm-hmm.
And it was a free-for-all all around the country. So for years and years, I valiantly fought. And I watched them doing all this nonsense. I mean, they did unbelievable stuff. At the same time, I was not only disinvited from having patients sent to me for coronary angiography, but given the fact that now the chief of vascular surgery, the chief of cardiology and of hypertension, and the chief and everybody else was basically saying, you're done in the heart.
Wow.
And so I doubled down on peripheral vascular disease, on renals, that Lara was still very supportive of. But honestly, no matter how tough I was, and this was really before we began to see patients.
Mm-hmm.
And it was sometime around this time that I actually did organize a vascular center at Cornell.
Wow.
And I had one of the vascular surgeons who was actually a friend, and then the guy who was the chief of the burn unit. Not burn unit, he was a wound healing specialist. So we set up a vascular center with the blessing of the chief of the chief of surgery, although the guy who was chief of vascular surgery was not crazy about the idea. So it lasted very short time. So we had 3 guys, and then of course a couple of the vascular surgeons who were not included because they were asses, and we didn't want them. And we were just getting them. We had our own board assigned and our nursing staff. We were training people.
Cool.
But then they cut it.
Really? How long were you guys up and running?
Couple of months. We were just beginning to get organized. So then I looked at the 2 guys I was doing this with, and I said, hey, guys, there's this cardiac hospital called St. Francis out on Long Island. And it was one of the most prominent cardiac surgery programs anywhere in the country.
Mm-hmm.
They had a terrific reputation. And one of our ex-radiology residents was now the chief of radiology.
Okay.
And so I said, you know what? Why don't we go where the old thing with why do you rob banks?
Yeah.
Because that's where the money is. So I said, why don't we just go where the patients are, vascular patients?
Mm-hmm.
I said, I know that St. Francis is a very active cardiac surgery program, and I also know that they do nothing in peripheral vascular disease. And I know so because I know the chief of radiology.
Right.
So I organized a set of meetings between the 3 of us and the head of the hospital, and then chief of cardiac surgery, and all sorts of various people. And we began to explore how it would look. And they just could not understand why anybody would want to do that. It was that foreign a concept. They did coronary angioplasty, they did coronary artery surgery, but the leap into peripheral vascular disease was something they hadn't even thought of.
Wow.
And so at first we were very excited and we thought this was all going to work. And the next thing we knew, a couple of months later, they said, you know what, I don't think we can really do this. And then, of course, a year or two later, they started their own.
They did it?
Yeah, they now have a very active angioplasty and peripheral vascular service. So timing is everything.
Mm-hmm.
Where you are is everything. And even though I had done the first angioplasty at Cornell, I had done the first stent of any sort at Cornell, I did ask Eric Martin, he had, from Columbia, I didn't have to hide because I had offered him a position.
Sure.
So, I called him and I said, listen, Eric, you've done a couple of drainages. I'm trying to get that going here at Cornell, but they are very reluctant to send me any patients for nephrostomies and for abscess drainages and stuff like that. They said it's very dangerous and seed the tract and, the usual crap. And could I invite you to give grand rounds, and I'll try to get everybody else to come, and perhaps, you can help me to get that moving. And sure enough, he came over and we did that. And because of the renals, I continued to have a pretty decent volume of angioplasty.
So actually, I wanted to dig in a little bit into the renals because I thought that may segue, and you can correct me, but something I reach for on a daily or at least very weekly basis is the SOS catheter. And I thought maybe that innovation was kind of born out of necessity. If you're doing a lot of renals and then you're starting to do a lot of renal interventions, that you need catheters that are appropriately fit for that task.
Actually, the first thing, the invention is a very interesting thing. Very early on, I came up with the idea of a microcatheter, and the SOS open-ended guide wire was made in the 80s by USCI Bard, and it was the first microcatheter. And believe it or not, I even came up with the idea of trying to make that into various diagnostic catheter shapes. And I wrote to Bard, and I had asked them to do that. I also asked them to put an angioplasty balloon on that with a tip occluder.
Wow.
And a little hole for a balloon. And many years later, Cook actually made such a thing.
Sure.
So for angioplasty, the first thing I did was I took the Benson wire and I just put a curve on the tip so that the Benson wire could cross into the renal artery without poking a hole and sort of go into one of the branches.
Gotcha.
And then I, believe it or not, invented a couple of other guide wires. One was the so-called New York Hospital wire.
Okay.
That was a modification of the Rosen. And ironically, I took the Rosen J tip, which was a very stiff tip, and it didn't really fit into a renal artery branch, and I straightened that out. So now I had a stiff catheter that could go into a branch and was stiff enough. Remember, we had very large, blunt, 5, 6, and 7 French. At that point, we had 6 and 7 French catheters.
Yeah.
And crossing across, even if you have the guide wire across, pushing it across, a stenosis was not so easy. And by the way, we didn't get into how in the early days there were no pre-shaped catheter shapes. They were very, very expensive, which is why they got re-sterilized. So the coronary catheters got re-sterilized, and Cobras, which were around, and that was pretty much it. And so everything else you had to make yourself out of what we called Kifa tubing. It was red Kifa rubber tubing that came in big reels, and after the cases were done, the nurses and I would sit down and make catheters.
Wow.
And you made catheters by cutting off the length of catheter wire, and then you took one end and you held it into a Bunsen flame.
That's right.
And that flared the end, and you had the cap and a locking piece that's screwed together. The cap went under the flare, and the locking piece went and screwed into it, and so they held. So that was the injection end.
Yeah.
And then you took the other end and you put it high over the Bunsen flame, and you had a guide wire, an 018, 038, well, 035.
Sure.
Guide wire inside, and you gently pulled the two ends of the catheter over the wire to taper it.
Wow.
And you took out the wire, dunked it into cold water, and with a razor blade, cut it, and then on some very fine sandpaper, you sanded it smooth so the tip of the catheter would be nice. I even made pigtails when they were deemed to be too expensive.
Sure.
By curving the tip and putting inside.
Yeah.
So I had a little advanced knowledge of how to make catheters. That didn't hurt.
Of course.
Then I came up with the open-ended guide wire. But even prior to that, I said, to Boston Scientific, they made the first really nice angioplasties, catheters. And they were 7 French for the renals.
Wow.
And so I said, why don't you... And it was very, they were fairly stiff. And to make the right angle turn from the aorta into the renal artery, it was a bit of an art. Sometimes you'd pull the wire out. And so I would pre-curve the shaft of the wire, the stiff part, so it would fit at the aortorenal angle. So now I had the tip curved a little bit, and I had the shaft curved at a right angle. But in addition, I had Boston Scientific not steam, but make the renal catheters with the sauce curve. So the tip was curved. So as the catheter went over the wire and it reached that right angle bend, instead of pulling the wire out of the renal artery and up into the aorta, it followed the wire because the beak pointed, if you turned it the proper way, into the renal artery. So that was one of my first other ideas. Then I hurt my back I can tell you exactly because my son was born in 1980 and I lived on the west side of Manhattan. And in those days I commuted to work from the west side of Manhattan to the Upper East Side to Cornell by jogging.
Wow.
And so I jogged. Not only did I run up the stairs, but I jogged. And again, that was not an everyday activity.
Okay.
Well, it was beginning to get there. So anyway, I hurt my back jogging, and I had an acute herniated disc.
Ooh.
And in 1980, I was 38. The treatment at that time was you lay on your back for a month and do nothing. I literally could not carry a carousel. And so I said, how the hell am I going to do angio with the lead apron? So I went to work, and I actually have a lecture called I should have sent that to you before we did this.
What's the lecture?
But the title is Invention and Innovation, How To. So that's why it sort of pissed me off that it took SIR up to this year to give me the Innovation Award. It was like, what the hell have you been waiting for? So I knew that I couldn't put a lead apron, but I also couldn't not do cases. So I had a fellow called Sue Hilton, who was about 5'2", and coincidentally, one of her fellows was a guy who had just come from Syria. His name was Suhail Sadekni. So I said, I have Suhail and Sue Hilton. And so I finally figured out Sue was already wearing all sterile stuff, and she was very little. So I would put on a sterile gown, get all dressed up, except without a lead apron.
Okay.
Put my arms around her and literally work over her shoulder and around her waist during critical periods when I needed to do something. So one day I said, Sue, you really are an idiot to let me do this. And I called her, you're a dummy. And so then I invented the dummy. The dummy consisted of two IV poles with a broomstick across, tied together, and 2 lead aprons, the whole thing covered with sterile sheets. And then I got all dressed up and I worked behind it. Well, that was great until somebody leaned on it and the whole contraption fell on the patient and the entire sterile field was gone and it was done. So then came dummy number 2, which was a pneumatic, height controllable, lead moving thing formed almost like a Roman chariot with an angular wings, and it had a pneumatic height adjustment, and it rolled on roller bearings, and it was commercially made, and they were just beginning to sell it, and that's the end of this story. So that was one of my first inventions, the sauce chariot.
It's a sauce chariot. Okay, well done.
If and when you have time, I mean, I haven't yet begun.
Haven't even scratched the surface. Well, a lot of rich stuff to dig into. Tom, thank you so much for donating some of your time on Saturday. I'm glad we were able to get you up and running. To our audience, thank you for listening. If you guys enjoyed the show and want to check out the podcast and want more notes on this, we'll put out some show notes, and those can be found at www.backtable.com. And remember, the show notes are where you can find free CME to some of our older podcasts. For those interested in supporting the show, like, subscribe, share the podcast on social media. Dr. Sauce, Tom, thank you so much for coming on. We really appreciate you sharing your stories, and we might have to get you back on to kind of get into some of the other stuff.
Well, Chris and Josh, I want to thank both of you. Truly appreciate it.
Of course. Well done, sir.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Don,
Michael Barraza,
Jacob Fleming,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson.
And Delaney Aguilar.
Social media and PR by Ann Dang.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.